Hello everyone. Pleasure to be here. Saturday morning, nice and sunny. What else would I want to do? No, I very much look forward to these things. I think I've presented at least one or two. Have a good relationship with Oscar BC over the last number of years, and I'm excited to actually be back and share an update on the work specific to our provincial eForms solution. So Oliver Thompson, Director of Provincial eHealth Projects for PHSA, so the Provincial Health Services Authority, really leading a portfolio here, working on behalf of the ministry, really focused on increasing access to and sharing of clinical information. The access to side of it, you might have actually heard of Care Connect, the Provincial eHealth Viewer. We're in the midst of deploying that provincially across the province so that all physicians have access to all the clinical information, or a significant amount of clinical information that actually is available within the health authority. So that's available today for all EMR users. And we worked with the Oscar community to develop a quick launch button so that you can get from your EMR to our Provincial eHealth Viewer in a matter of seconds. We can talk about that later on. That's not the subject of today's conversation. Second one is the EMR to EMR interoperability. So the ability to actually share information electronically. Wow, let's actually get away from the fax machine and have GPs send electronic referrals to specialists. Let's have specialists automatically reply to the GPs. Let's actually build that information highway between those two groups, as well as the health authorities. I know a number of times GPs in particular are asked to share information about their patients with the health authority. Can we get away from the fax so we can actually start to move that information electronically? But today's conversation is about forms and paper forms, the form process. So before I get into that, Rachel Barker is joining me today. So Rachel, do you want to give a quick intro to you?
Sure. Do you want to do that intro, or do you want me to do that intro?
No, just for yourself.
Okay. Hi, everyone. I think some of you may have met me in one of my past lives before. So prior to this, I was at Doctors of BC for about 2 years. And I have been to these Oscar meetups in Abbotsford in person. And it's very nice to be here again. And it's also very nice to not drive out to Abbotsford, I'm not going to lie. Prior to that, I was actually with a different vendor for about 8 years, leading one of the technical teams over there. So I've got a little bit of technical experience, a little bit of physician engagement and physician advocacy experience. And now I am over with Oliver leading the EMR engagement and integration across some of the projects on the team.
And I'm so glad to have Rachel with us.
Very glad to be here.
Great. Okay. So let's jump into it. So we've got an hour with you. The presentation is about half an hour. There's a little bit of a show and tell. We get to play a little bit because I know we like to play. And then I'll save a lot of time for questions at the end because I assume there's going to be a lot of interest here. So to go through the vision, what we want to achieve, give you an overview of what we've actually developed, because this isn't a dream, this is real. Give you a status update of where we actually are, and then turn around and actually talk about, well, what about us? What about Oscar? And what does that look like from your perspective? Sorry, was that a question? No. Okay. So the elevator pitch, all healthcare forms, always up to date, all points of service, pre-populated where possible, delivered electronically. And the asterisk there is we're not looking at internal healthcare forms within the health authority that they use for their operational processes. We're talking about communication between two parties which really cross an organizational boundary. So forms you need to complete for the health authority, forms you need to complete for specialists, forms you need to complete for Road Safety BC, ICBC, anything which you've actually got clinical information that you need to pull out of your EMR, contribute to, and send somewhere, that's our scope. Just a quick refresher, we have a problem in our healthcare system. We're not unique to it. Canada is like others. We are, I'd say, further behind, is that we have our addiction to fax. We love fax. We continue to use fax. We have countries which have moved, try to move away from that. NHS has banned buying new fax machines. Yay. Because they're actually moving towards more electronic means. So our healthcare system is not there yet in Canada, especially in BC. We're still based on fax. When I've been working with physicians and with their vendors, Ken in particular, over the last, actually John Yap too, the last 2.5, 3 years, extensive consultation process with vendors, with physicians, with form owners, and no one seems to be happy with the paper process.
So it doesn't
Different
start.
EMRs.
You can practice with what they have on there now.
I think we're gonna have to mute people.
So whenever you're done that, let's.
Cindy or Ken, I think you have the power to mute people.
Yeah.
Okay. So the paper process, we haven't found anyone who's actually happy with the current process. I'm going to argue that there's actually a significant amount of cost we're putting into the current process. So we're actually have, I'm going to say hundreds of people whose jobs solely depend on getting a fax and typing it into a computer system. So we're already funding this process, which is inefficient. Let's redirect that and actually get better service, better care for our taxpayer dollars. Everybody thinks fax is they're scared of the technology side. What could go wrong? There's lots of breaches. There's issues there. Great. Let's look at the risk on the fax side. There are risks which we just commonly built in. We accept misdirected fax, privacy investigations associated with that. You can't really trace it. Where does it go? As soon as it comes off a fax machine, it falls off the table. Where is it? Who actually gets access to that? There's no auditability to that. So there are risks with the current status quo. And lastly, we're going to argue that fax is a barrier to improving the efficiency of our healthcare system. And I have some examples of that, where because we're basically exchanging images, we can't act on that data in a fast and immediate fashion. So here's our problem. 2.5, 3 years ago, I had the chance to actually bring all the EMR vendors into one room and actually have an open conversation around what's the problem from your perspective, and then evaluate that with a number of physicians working with us, and came up with this hit list of really the top pain points by physicians and EMR vendors of what's wrong with today's world. Solutions were really sort of fourfold. Governance, let's have some structure around who can create a form. Why do we have 5 cardiology referral forms? Sorry, 30 cardiology referral forms. Why don't we have 1 or maybe even 2? Hey, let's get down to 5. So we need governance around that. No single source of truth to go find the most up-to-date one. No acknowledgement by the health authorities that there's effort to create forms in the EMR. So the health authority says, hey, here's a new form, change it. And then the vendors are stuck in the middle going, really? Are you going to pay for this? So who's going to do this work? Why are you changing the form after every 3 months later on? We don't care if your fax number on the form changes. That's different. Another set is really form standards, poor quality, lack of standards information, unrealistic expectations for actually completing the forms. A PDF repository, we're actually working with Pathways so that all the health authority forms at least are actually in Pathways and up to date with the most current version. Sometimes Pathways have had the more current version than the health authority did, so we resolved that. But at the end of the day, those are all piecemeal solutions to some of the problems, and the electronic repository, which we'll talk about today, really covers them all. This is where we want to get to. This is the nirvana from our perspective about addressing all the issues that has come across by all stakeholders. So what am I talking about? So you are a clinician. Your goal is to, your desire is to exclusively work within your EMR. You bought an EMR, you're using it, your staff are using it, you've got your clinical information there, that's where you want to work. So you use your EMR to search, complete, and send forms. We're not asking you to leave your EMR. Lots of healthcare organizations are saying, great, well, we'll build a website and the physicians will come to us. Not gonna happen. So we've redirected all those thoughts to, on that, those discussions to say, no, it has to be in the EMR. And this includes saving to draft. So you can't, you have to have the ability to create a form, save it, come back to it, distribute that over a number of people. MOA does one part, physician does the other part. You can manage that workflow within your practice. Cardinal rule. Second thing is a central repository forms that has the most up-to-date form definition. And this is really the up-to-date part. So we want to connect a form owner who has to make updates to the form, give them the freedom to actually control that form, make changes to it, and put it into a repository, which you as a physician, you as a user, immediately go and actually grab. So we're talking, literally real time. Someone can actually save a form, have that change, and have that change appear in your EMR, moments later. So really shorten the implementation time to get to the form, shorten the cost associated with that. And a key aspect, I think, from your perspective is you'll always have the most up-to-date form. And I've heard horror stories of physicians and clinicians completing forms. It's going off only to get the fax 2 weeks later to say, oh, you completed the wrong form. Can you resubmit? Why? Auto-population. We understand, and I know Oscar does a great job with this, pre-population of forms. If you have data in your EMR, why would you ever want to type it back into a form? Let's get to the point where leverage the technology you actually have, complete the information, put it into a form so that that can actually be shared. So you don't have to actually type it back in. So really from a reduces time from a data entry and effort perspective. Form guides the user in completion and really enforces required fields. One of our stakeholders we're working with, Lower Mainland Medical Imaging, 135,000 medical imaging requisition forms a year. Their stats are up to 20% of those forms require a phone call back to the user because some information was missed. So that's where there's an opportunity, and I know there's some sensitivity around here. Everything can't be required, so there's got to be some feedback. But you know, if it's the few fields that are absolutely mandatory, then it have to be completed before they go. Let's actually enforce that so you save time throughout the whole process. Get rid of those manual phone calls back to say, can you please answer this question because it's important to our workflow. And lastly, sending the message electronically so that the downstream system can receive it and actually do something with it. So on the back end, the initial benefit is no more data entry, but the benefit for you also is they've got real data. They can actually then respond to that real data, some of them in real time. So we'll be talking about some opportunities where you submit a form, they review the form, the clinical system reviews the form immediately and provides you an answer back right away, as opposed to having to sit on the fax, wait to get data entered, wait to get assessed, wait to get a fax back. So the real-time back and forth communication. And all of this, standards-based, non-proprietary. I know that's a very key aspect of the OSCE community. No vendor lock-in. It's not a custom one-app solution. It's not for one form in this form. Again, it's all forms, all points of service, all EMR vendors. So that's a lot to take in right now. I'll pause for if there's any questions there, because that's kind of fundamental to us going forward.
No questions in the chat yet. Did anyone have any questions on what Oliver said to date? We want to head right into a little bit about like what's under the hood.
Okay. So I assume we got some clarity on that. Okay. So technical challenges. What did we have to overcome? Because again, this is real today. So what do we have to come? So one is sharing discrete information. Discrete, I mean real data. I mean when we ask for a height, we're not getting a picture of a document, which a fax is. A fax is just a picture of what's actually completed. It's the real data. It's actually the number. It's the value, which can go into a computer system, and that computer system recognizes it as a real value. So sharing. So we've got discrete information in your EMR. You've captured it. You've put it in. You've typed it in. Right now, today, we fax it, and on the other side, it comes out as an image. It comes out as a picture. And sure, you've got some fancy tools to go on and read it, optical character recognition. It's pretty good, but it's not perfect because you're not getting the real. You're taking a real data element, turning it into a picture, and interpreting that picture to turn it back into a real data element. And it's a workaround. Problems with that: data entry. It's costly. There's lots of people there typing away. It's slow. There's a stack of paper that people need to go through, and they need to get through that list. And it's prone to errors. Guaranteed, there's a 2 to 5% error ratio for actually entering that information in. So let's get rid of data entry. It's old school. And secondly, the inability to respond effectively. So right now you get a receipt on your fax machine saying transmission sent. Okay, brilliant. Can we go a little bit further than that? Can we go to the making a referral to the diabetes clinic to actually have a receipt back saying, thank you for your submission, we've received it, current wait time is 2 weeks. Better yet, special authority forms. You're actually making an application for a special authority for your patient. Can we get to a point where you submit the form, they adjudicate, and immediately come back and say, approved? This is the world we need to get to. Second big technical challenge is integration. How do you get the systems to talk to each other? And within the healthcare system, we've done a lot of work to actually connect all of our systems. It's complicated. It's really difficult. How do we imagine extending it out to primary care? Where in BC, or so community-based practice, specialists are involved too. How do we get to actually do the integration with the 9 EMRs that operate in BC? What about the 27 EMRs that operate in Ontario? Because this is not a BC problem. We're not unique here. This is a this is a national problem, if not international problem. So this is where I'm gonna ask the non-technical people to top up your coffee, because this is where we're gonna dive into a little bit of the technical side, and then just introduce 2 concepts which we're gonna build upon in the following slides. So taking a slight little detour, how we're planning on solving those technical barriers is through a new standard which has been out for the last number of years, 5, 6, 7 years, called FHIR. So Fast Healthcare Interoperability Resources. Everybody calls it FHIR. No one calls it by the long name. And it's an international standard. It's been widely adopted across the world. It's really the language for exchanging discrete clinical data. Again, the real data. We want to send the height as a real number and have it come out the other side as a real number. It's a core standard for HL7, so Health Language 7 standards, again, and it's in wide use across the world. And more recently, the US has actually mandated the use of it for some use cases, including getting access to patient information. So it's solid. It's not a Canadian sort of invention off the side of someone's desk. It's actually a real thing being adopted. If anything, Canada is actually further behind than a number of other countries in its adoption. So that gets us the how do we address the discrete language part of it? You got the real data there. How do you address the connectivity part? Well, here comes along SMART. I've actually never read this. Substitutable medical applications, reusable technologies. Oh, that's an ugly one. Basically, SMART is the glue that actually glues 2 systems together. It's a standard-based framework that actually allows the development of a healthcare application. Think of an app on your phone and actually being able to use, getting implemented in a number of systems. So the app on your phone going into your phone. It's those 2 glues there. It's the integration framework. It looks after the security side of it, the authentication side of it. What data can be shared? I don't want to share data. Okay, sorry, I don't want to receive data. I just want to send data. I only want to send a little bit of data. I want to send a whole bunch of data. Has all that privacy and security framework put around that. And once the vendors have implemented this framework, this SMART framework, it's extensible. Well, it's a foundation for other applications to actually build. So again, the EMR does this once, and once they've done this once, other applications can sort of fit into the exact same framework. So it's very, very leverageable for other solutions.
Oliver, I think it didn't make it into this presentation, but one of the analogies I really enjoyed on this is when you're building a house and they build in an electrical socket to the wall. It's just there for you. There's an electrical socket, and you can plug in a hairdryer, you can plug in a toaster, you can plug in a refrigerator. Like, the socket doesn't care what goes into it. It just knows how to deliver electricity to that thing. So it really is just putting in that infrastructure that you can swap in and out many different applications.
Yep. Cool. So put the 2 together. Now you've got SMART and FHIR. Okay. So for those less technically interested, you can come back now. You can take me off mute if that works. So getting back to the solution, to the problem we actually have and the solution that we've actually built. And I probably should have put a slide on the journey here. We've actually been working in collaboration with all the vendors in BC, as well as Ontario MD in Ontario, to go through this process. So it's been 2 years of dialogue with the vendors. It's been a collaborative development process. So we haven't just gone and done something and thrown it on top of the vendors. It's back and forth, back and forth, back and forth. We did a pilot, we did a testing. We actually worked with a couple of vendors to actually test this thing all the way end to end within a pre-production environment. Shared it with all the vendors, got agreement that yes, this is the architecture we want to do, and now we're actually on the implementation path. So there's been a lot of collaboration with all the vendors in BC, including Oscar BC. So what is it? So this gets down to the actual nuts and bolts of it. So we have a form designer, which allows a business user to go and actually create a form. We provide them with best practices on what to do, how to create a form. We provide QA on that to make sure that the form actually works and is functional. We have lots of opportunity here to work on the UI side of it, do the testing, make sure it's a really optimal, really skookum, really useful form from a physician's perspective. Once we promote that into production, it sits in a repository. What we've actually done, because we know we have an internal need, because our clinicians also complete forms for other organizations, ICBC, Road Safety BCs, and they're not in our clinical system, so we have a need to actually access these forms too. So we built a form viewer which goes into the repository and makes the form usable. So it has all the checkboxes and the radar buttons and the drop downs and the dates and all this stuff. Everything you could possibly think a form should have is available within that form viewer. When we press send, it sends it off to its downstream clinical system. So when we start talking to the EMRs, the big question is how will the EMRs play within this ecosystem? Well, first conversation was, well, great, we'll get access to your form repository, we'll download all the definitions, we'll show them within our EMR, we'll package up the message, and we'll send it to the downstream clinical system. So basically, do the exact same thing we actually did with the form viewer. The vendors were excited about, well, at least you got a form repository where you got all the definitions in there. Well, that's good, and that can be updated by the business owners. Well, that's good, but that's 9 times making a form viewer, 9 times making a submission process. Well, there's got to be a more efficient way. That's where Smart on Fire actually comes in. So Smart on Fire allows the ability for an EMR, any EMR, which is Smart on Fire enabled, to basically plug and play into our form viewer. This is what we've actually proved out with 2 vendors in BC already. So with iClinic and Intrahealth Profile, basically the EMRs implement the Smart on Fire framework. Our eForm viewer is wrapped around this Smart on Fire framework, and we plugged them in together, and it was basically plug and play. What's shared? So going from the EMR onto the form, this is the pre-population side of it. So basically the opportunity to pre-populate is quite extensive. We're talking hundreds of data elements can go across if the EMR collects that within a discrete way. So if it's in a note, it's not very helpful to us. If it's actually in a discrete field, if height is actually where it should be documented discretely within the EMR, then that's right for pre-population. We're starting small. Patient provider is on every single form. Great, let's actually work with those resources, get that functional, and actually have that information go across. Build upon there. What's next? Height, weight, some other observation. Where can we end up? That's really going to be driven by the user community, by the vendor community, because whatever path we want to go down, we can actually steer it. That's pre-population. So that's getting the data into the form. What do you get on the way out? Because at the end of the day, you need to have a record for medical legal purposes. So what you get on the way out is the completed form, both in what we call a FHIR bundle, forgive the technical talk, which is the discrete data just wrapped up within this FHIR message, and a PDF, which you can actually put into your document repository. So from a user's experience perspective, they're in their EMR, they open the form, it pre-populates with data through this process, again, starting with patient provider, other data elements can grow. And then when they press send, they get, for all intents and purposes, a PDF back, which they can store within the repository. They can also get the actual discrete data to actually also put within their EMR. What also happens is when you actually press send is the discrete data, the real data, again, goes down to that clinical system. Knowing that Oscar lives in a dual world, there's both the local installs within a practice, and there's also cloud installations. This implementation can happen both in a server room in your office or connecting up to the cloud. Completely flexibility. If it's local, it's all within the EMR's environment. It sits there. It doesn't touch the internet until you press send, and it actually sends the message out. If you're using the cloud installation, then all of the activity is really happening within the cloud. We're starting with the local implementation because it's just easier, build trust with the vendors, gives them full control over those things, gives them opportunity to beat it up. And then the only thing that's going out is a message. Where we will get to in 5-10 years, I assume, is actually moving everyone over to the cloud, but we'll get there. There's no intention to force people there. You don't have to go there. I just think as we go down, the economics of it will actually just make sense in that direction. So again, another big concept. So I'll pause there for any questions. Anything in the chat?
No questions so far. Is this just like very clear and straightforward to everyone, or is anyone like, I missed something like 4 slides back, and then what is this term again? No stupid questions. Oh, got a couple private ones. So one is about the pilot. So the answer to that is it's been piloted, it's been proof of concept right now with IntraHealth and iClinic, just to work through the process, get everything streamlined for EMRs that are coming on going forward. I think we'll talk a bit later about where we're at with Oscar, but we've actually got, Oliver, I believe 7 of the EMRs in the province signed on right now. And most of those sort of actively working on development or investigating the technical path forward. So we've got some proof of concept done, and we have quite a bit of development in progress now.
Yeah, and actually, just in terminology, we did a proof of concept a year ago to prove out the technical foundations, and then we evolved that to a proof of technical integration. Again, our words, but I think they're important here, because the technical proof of integration basically we worked with iClinic and Profile to put this in a pre-production environment, so that it's no longer playing around on the side of a desk. It's actually, okay, so does this fit with the core product that they actually have? How does it actually integrate? Is this implementable? And the result coming back from that was, yes, it is. It actually does work. This is how it does integrate in here. Here's what the workflow looks like within our EMR. We figured all that part out now. Now to take it to the next step is basically just transferring that to a production environment.
We have one question about data entry. So just the concept of right now forms, I think when you enter them, you can enter kind of whatever you want and fax them off and call it a day for the most part. So just about this solution, there are some more guardrails essentially that the form owners can put in at the point of service to say, this has to be this type of a value, or this has to be, this can't be blank before you can submit the form directly to their system. And then that's kind of nice from a workflow perspective, because I mean, at least what I've personally seen with some of the vendors is the physicians get stuck requesting the forms. The form owners are not actively involved with each vendor. And then you find out, because the form owners are phoning the physician saying, well, we rejected your form. They're like, why? Oh, well, this field has to be mandatory. And then it's another 6 weeks for the vendor to add it. I think on Oscar, it probably moves a bit quicker because people just go in and fix it themselves, as is the benefit to the Oscar community. But this is, the form owners are able to divide that at the point of service. And there will be probably some people that maybe have to bring their level up a bit in terms of filling out the forms appropriately, but it'll also hopefully almost eliminate forms getting rejected for incomplete data as a result of that.
Yeah, and we do recognize that there is sensitivity from a user perspective, because your first thought might be, oh, damn, a lot more information is going to be required. What happens if I can't complete it? Am I stuck and I can't submit a form? And I think our solution to that is, one, because there is one form experience across all users, we're upfronting that clinical experience, so that when, if you look back here, this form designer part of it, make sure that there's physician engagement at that point to say, yes, this is usable, this makes sense. Will we cover every scenario? Probably not. The odd scenario will slip through. However, once we actually discover it, it's not just a problem you're actually having as an Oscar user, it's a problem you're having as a physician in the province of BC.
Yeah.
So, and the ability for us to go in there and say, oh, in this scenario, this thing can't be required. Great, let's fix it. And when we say fix it, we mean fix it in a matter of days, as opposed to any lengthy time, days for all the EMRs, as opposed to a significant amount of time across all the EMRs.
And we have a couple more quick questions you could probably just pull through. So one is if the forms are available for both cloud and local installs, and Oliver, I believe the answer to that is yes. So as long as you have connectivity for your Oscar to be able to connect to the eForms repository and pull down those forms in real time, like whether it's a locally hosted or a cloud hosted, shouldn't matter.
Exactly.
Yeah. And I think, nope. I think we'll talk about cost to the user, and the answer is no. So this is something that's funded by the ministry. There's a lot of benefit to the health system here. So this is something run by PHSA, funded by the ministry. The vendors are getting compensated for building this, for their time and effort. And the expectation in that is that there is no cost passed on to the physicians. This is something that is very good from the health system, not just from sort of a data entry and accuracy and patient safety perspective, but like this is something where we've talked to teams that have dozens of data entry clerks and they can't keep it staffed, and their turnover is high, and it's incredibly frustrating and expensive for a lot of these major form owners. So that this isn't something that's getting passed on to the physicians. This is something that the expectation is the health system itself is going to cover and receive cost savings on top of that.
Yeah, and on top of that, within our funding model, we've actually built in some funding for the vendors themselves, because we know that supporting this technology on an operational basis, there's going to be some work. We don't know what it is. We don't anticipate it's going to be a lot of work, but we know that there's going to be something. So great. Let's recognize that the form owners and the health system benefits. Let's pay for that and actually get that in the hands of the vendor. How that looks across all the OSPs within Oscar, to be confirmed.
I do want to get this quickly. We talk about this a bit later. There's some questions about the shifts in the market with some of the acquisitions. So, Input Health, Well Health buying Intra-Health, et cetera. The vendors that we're currently working with.
If we can defer that, because I think.
Yeah, you want to talk about that a bit later?
Yeah.
Yeah. So I think the last one that we have outstanding is just about attachments, Oliver. So is this what? Maybe the question is, when will this support attachments?
Very good question. So the one technical gap we haven't closed yet. I think we've closed. I think is this the only one that's outstanding? I think so. It's half around attachments. The technology supports attachments today, but we haven't optimized the process for the integration with the EMR. So right now, a form comes up, attached, it clicks the button, it goes down to that little desktop. And you can find a file on your desktop, and you can actually attach it. So the attachments functionality works. It's not optimized from a workflow perspective. So what we need to do is then work with, and we believe it's each individual vendor, because each vendor does it separately, and figure out what's the best way to get attachments from your EMR onto this form. We know that some vendors, don't know for Oscar, but when you're doing a referral form and you want to attach something, there is functionality to go and say, open up and look at the chart. Oh, there's the report. Click, 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 click. Attach it to the letter, which then actually gets faxed out. So we understand there's that functionality there. How do we make that functionality available to the form so you have the exact same user experience?
We opened the question floodgate. So.
Okay. Let's pause on that.
Want to hold off? Okay. Keep going.
Let's just get through some of the rest of the slides. Yeah. Okay. Privacy and security hasn't been brought up yet, but I will hedge off some of those conversations that might come. So again, from a privacy and security perspective, we're talking integration. We're talking actually having a closer knit tie with the vendors in the province. It's kind of like it's the opposite of what we did a long time ago, where previously we've actually we had within the Lower Mainland, we have Accelerus delivering clinical reports to distribution to vendors. In the interior, you have CDX delivering electronic reports to vendors. So we've been sending you electronic information. This is the flip side of that, where you actually send us clinical information. So again, it's a new frontier for us. Privacy and security is a huge consideration on our side. So it's top of it. International standard adopted by a significant number of healthcare organizations. So there is a lot of attention being put on this and a lot of scrutiny put on this, because if Cerner is going to open up their world, well, Cerner's got a hell of a lot of data in there. So they got to make sure it's absolutely safe and secure, and there's no opportunity for breach. As I mentioned, deployment in the local or in the cloud environment. So within your local environment, you've got that protected sphere around you. Great, keep it protected. The infrastructure we put in, scan it for viruses, for malwares, take it apart, go in there, take a look at the code, make sure you're absolutely totally happy, secure that it's actually safe to work within your environment. We've done the PIA on our side. We've done the security threat framework assessment. No, that's not right. Security. There's an R.
That should be risk. Yeah. Sorry.
Security threat risk assessment process. So we've done that. It's actually yeah, that's done. Key to this is data is only in transit. So the data is actually not held anywhere. So this solution basically picks data up from your EMR and delivers it to where you want it to be delivered to. Actually, sorry, where the form owner wants it to be delivered to. And there's an assumption that where you're, yeah. So we're not third partying this off. We're not taking it for analytics elsewhere. It's just a bypass all the way through to the end. And then just a comment. So this is something that actually it's funded by the Ministry of Health, managed and actually deployed and operated by PHSA. So and I want to have some fun now and actually take it in action. Let's take a look at this in action. So I'm going to show you an example. It showed up on the wrong screen. So here's our fake EMR. So you walk into your office in the morning, you sign on, and today you're signing on as Antonia Stark. Okay, great. You sign on to your EMR, fantastic. You go through your day. You actually look for, your patient comes in, and great, Theo, we're going to be looking at Theo today. So what we want to do is we want to make a referral to the cognitive therapy. Oh, where'd it go? Fine, there's my demo environment. This is not my demo environment. I think that's it.
Oh, maybe use the link.
No, where is it?
It was in demo, and it was in demo as of yesterday, so someone may have helpfully removed it.
There it is. There it is. Sorry, I probably have an old cache. Okay, so you want to do referral to the Cognitive Behavioral Therapy Program referral form. So this form would actually come up. This is either embedded in your EMR, so it's absolutely seamless, so it looks like it is your EMR. This is a different window if you want it to be. This is all local EMR implementation discussions. You'll see all this information here. There's Theo, all his information, female, the provider information that's actually been populated. We've got all smarts in here so that, is this PHN not from BC? Okay, let's say you actually have a patient from, Manitoba who comes in. Great, we can actually put in all that, the smarts around there to gather the right one. Patient information, typically not interesting, not sexy. Great, get it off your screen because oh, look at this. The patient I picked is not 18 years or older. I can't go on. That's interesting. So let me change the birth date. Let's go back to 1970. Are they, yep, there we go. Great. They're now more than 18 years old. So now this information comes in. So this is an example of if you would have completed the form for a younger patient on the piece of paper and submitted it in, you'd wait a few weeks to get back and say, oh, they're not eligible for this program. Oh, damn, why don't you tell me that when I actually just completed my form. Stuff like over here, the clinic really wants you to go through and actually have an appropriate discussion with the patient and actually confirm that yes, I've actually gone through this process. If you haven't gone through it, then you can't actually submit the form.
And I'm going to answer a quick question from earlier that just came up a second time. The data that's going to auto-populate in here is as good as the data that you're entering into your EMR. So if you haven't entered in, in this demo environment, we didn't have date of birth for this patient auto-populated in that. It might just be the form, but if you don't enter date of birth, it's not going to come in. You're going to have to enter it manually. But absolutely in the live environment, if you have date of birth in your EMR, it will come in. So if you're not fully using your EMR and you don't have all the data in, it's not a big deal. You can just manually type it in. It's going to work very much like your Oscar forms work today. So if it can auto-populate, it will auto-populate. If it's not in the EMR, it's not a big deal. You can just type in the information.
And then here's a good example. So I've actually switched to a different form. I'm not going to go through the details of this because I can't actually answer questions on it. But again, there is your date of birth there. So it was 2016. This is an example where we might get to a point where the patient and provider information will just be lapsed because it's so repetitive, and you know what it is. But again, additional features like the consent. Okay, so the patient consents to the appointment. Great, and they want to find out some information via text. Great, throw in your text number there, and you can collect it. It's really guided workflow throughout the actual form. Okay. And a quick plugin. So that, again, this is not about just forms. Forms is the biggest business problem we're dealing with right now. However, it's not the only thing. So this is where the Smart on Fire offers a bunch of other opportunities from an OSCAR perspective. Nothing to do with us. Maybe in the future, the ministry or health authority might want to offer some other app which is actually of use for your clinicians. But at the end of the day, there's a bunch of tools out there which are actually available. I understand you probably already have a lot of these in your EMR. But you know what? Isn't this the growth chart developed by the Boston Children's Hospital world class? Okay, maybe there's an interest of your constituents or users to actually start to use some of these tools. And again, once you have the smart framework put in place, plugging this thing in and actually getting benefit from it is a matter of hours, as opposed to not being able to get access to it. So, so EMR considerations, and then this is where we've got flexibility in the approach. If we build a form, the CBT referral form, doesn't mean you have to take it. This is basically it's a menu choice. So which forms do you actually want to have in your EMR? So what are ideal candidates? Well, ones that aren't in your EMR today. If you have the CBT one and you're happy with it, okay, well, maybe don't use it. If you don't, perfect. Forms that change frequently so that you don't have to bug John and John to actually make updates to these things. You leave the updates to the form owner. Forms that provide real-time information post-submission. So again, I mentioned special authority. If you can get automatic approval as opposed to waiting 2 weeks for approval, there's an interesting one maybe think about. What you don't really want maybe in your EMR is more complex forms that are embedded into a workflow. So if you've got 7 steps for a workflow and you have to do a form in the 3rd step, and it relates back to the 5th step, maybe let's not tackle that right now. Maybe in the future, but maybe not right now. And maybe forms that support additional user-friendly functionality. So this is where the pre-population side of it, I know from OSCAR side of it, there's a lot of really good, like your lab requisition form. It pre-populates, provides a lot of decision support. Fantastic, that's great. If we tackle that form, and we might not, but if we do, I'd suggest the functionality which we build has to be comparable, if not better, to ones you actually have before you would start to think about using it. So just a quick update. I've only got a few more slides to go through. So where are we, and what does this look like? So we are live today. This solution is being used for today's digital vaccine solution. It's going to be replaced over the next couple of weeks with a more robust, more larger focused one. Well over 1 million transactions have gone through the system, so it's been used more than 1 million times by health authority clinicians. So this is all the internal side of it. We're not live yet with the EMR side of it. We've got the 2 EMRs, IntraHealth and iClinic, which are targeted to go live within the next month or 2, and start to actually use that in a production environment. And as Rachel mentioned, we've got 7 EMRs in the province of BC that are really working towards a fall implementation. And we only have 2 holdouts, which I think will come sometime soon. So my last slide is what about me? Me being you. So what about you? What about us? So we're expecting this to be available by the end of this year, 2021. We're starting with working with all those 7 vendors to actually get an implementation path, provide support to them. So we're just at the beginning of that conversation with OSCAR BC community. It's the forms available that go live. This is a conversation with the OSCAR community. What do you want to start with? iClinic is going to be the first EMR going first. So, well, which EMR, which form is beneficial to your users? He said the VCH echocardiology requisition, top priority. Fantastic. I called up the person who ran the cardiac program at VCH. Do you want to play ball? Do you want to be in this? Absolutely fantastic. Let's start to work together. So this is where you get to identify, well, go back to that list that we reviewed before. Well, we're missing these 3 or 4 forms. Again, let's start small. Let's not go too fast. We're missing these 3 forms. Can we start here? And then we'll actually work towards that process to actually make sure that they're in there. And then as we continue to actually add forms to the repository, you'll be able to actually pick and choose which ones are actually most useful, again, within your local environments. 12 minutes for more questions.
All right. Maybe let's tackle the few we have in the backlog right now, and then we'll open it back up. So I know there was a question about whether there is going to be the John retraining fund for using Form.io for creating forms, and maybe just to speak to you a little more about how the form creation process is going to look now for the OSCAR community leaders who've been doing that.
Well, this is where I'm actually excited to talk to Oscar about it, because I think that we can actually learn a lot from what you've accomplished from your, should we call it more that sort of decentralized model. The model that we're actually enabling is let's give the power to the form owner so that they can create the form, and actually have a business analyst, a clerk at BC Cancer go and actually create those forms. We have a best practice process, best practice documentation. We have a forms committee, which basically looks at those best practices. Before a form is actually published in, we've got a QA process to go through. So, and part of that QA process, where's the role of the physician within that process? So I think we can actually learn from the OSCAR community around how you guys actually develop forms to get it out to the broader network and actually augment our process with your learnings.
Yeah, and part of the answer as well is, I think at this point, the EMRs are no longer running one step behind the form owners when a new form is released. So it's not a thing where ICBC puts a form on, they're like, we need this in all the EMRs, and then all of the EMRs, so the vendors or the OSCAR community, are running around trying to get this form in on time. Or something comes out and there's no instruction to the EMRs and everyone just has to put it together. So the form will be built by the form owners, for those large form owners specifically, and it will go out to all of the EMRs at the same time, one version. So we don't have to have 9 different EMRs building 9 different copies of the same form. There will still absolutely be cases where probably there are forms that aren't available. Maybe it's a divisions of family practice form that needs to be an OSCAR that needs to go up on the repository. And I think absolutely, like, there will be cases here and there where I'm going to say the OSCAR community leaders with that experience probably can pop on Form.io and create a form, but they don't have to all of the time like they're doing it now. It's really hopefully going to remove a lot of that burden. So I think the next question, Oliver, was around permissions within the EMR. So whether people can, for example, have their MOAs, if they're a physician, pop on and complete a form on their behalf.
Yeah, we fully support the save to draft functionality. So user one, and the way that works is user one, opens up a form, completes it, and saves it. When they save it as a draft, they don't get a PDF. They just get the actual the file bundle, so the actual discrete data, which then sits with the EMR. We give that responsibility back to the EMR to say, well, how do you want to actually implement that functionality? So does only that user have the ability to actually get access to that draft? Okay, sure, that's an EMR thing. Does it go within a group, within a clinic, or is anybody who actually has access to that EMR can get access to it? Where does it sit? Does it sit within a special draft area? Does it sit somewhere else? Again, that's all EMR functionality. At the end of the day, when the second person or the same person wants to go back and finish it, they find it however you direct them to, open it up, and then the whole process starts again. They open it back up. Their data is there from what they've submitted before. They complete the form, and you finish the process.
Yep. There's a bit of discussion happening in the chat that I think we can chip something in on about the importance of getting user feedback on these forms before they're rolled out to everybody, and what that process is going to look like. And I can say from our end, one of the things we're doing to help with that is Oliver's already mentioned that we have the form governance committee. We do have physicians engaged at that point on the best practices standards, but we're also looking at really helping those form owners with what a proper beta of these forms should look like, that they can't just complete a form and shove it out the door of the entire province and cross their fingers and hope for the best. And we're also working with Doctors of BC on those processes to really define bringing in the physician engagement. So it's not just like our little piece, we run the technology, build the form and shove it out there, and the implementation isn't our problem. It's the holistic, what do you need to do from the day that you have a new form to the day that that gets out into full production to everybody. And a lot of those steps are physician engagement at the beginning and beta testing with the physicians at the end. So we're really trying to steer that overall process and not just the technology with partners.
Yeah, thank you. Yeah, so any feedback or observations from this group would we'd greatly appreciate it, because I think what we're doing, we're not just creating we're not just digitizing a piece of paper. We're actually creating an optimized workflow so that you actually might have a form owner who says, well, these are the 18 things that I need to collect, and they create it the way that they want to. Is that the most optimal workflow from a user's perspective? Well, here's our opportunity to change that, to say, no. It shouldn't go 1, 2, 3, it should go 1, 3, 2. Okay, so does a form owner, they were maybe constrained by 8.5 by 11 PDF before, so they had to do it that way. We have technology, we can actually change that, we can actually modify it. So your input is definitely greatly appreciated.
Not a question, but a comment about that this is going to be nice, because often form owners will put out a new form, not tell anybody, and then it'll be months before anybody knows that the new form is out. And often, at least what I've seen, is they find out because they start getting rejected. And it's like, use the new form, and everyone's like, what new form? So I expect with this new process, if somebody tries that, immediately we'll get probably about 1 million phone calls, and then we will be able to go shame those form owners and get them to fix it on the platform. So that should cut back the time, I would hope, really significantly in that scenario. I think we've made it through all the questions so far that we had compiled. Oh, message. How will this impact physicians still using paper charts or completing forms hard copy if form owners are not restricted to standard page sizes? So Oliver, do you want to talk about maybe the web solution for a second?
It's an interesting question, because we're not at the process to say the PDF goes away. So the piece of paper is still there. So it's really the current PDF still exists, and we get to digitize that, so we get to actually make it a much more better user experience. If a form owner still needs to make a change, they will likely still be making a change to the PDF and then publish that, through Pathways or put it on the website. So it'll still be there, and then you'll have the optimized workflow on the website. So the PDF will still be there. So in a completely paper practice, go get the PDF, and everything is status quo. Getting alerted that there's a change, again, you need to figure that part out. Where there's also an opportunity is when you have a hybrid clinic, is all of these forms will also be available outside of the EMR. So this form viewer here is actually accessible externally by non-health authority folks. So today we can actually enlist non-health authority staff to get access to the form. So theoretically, if a physician did want to get on and actually, let's say, submit that special authority form to get automatic approval, they can actually log on to the website, get access to the form. Because of the process we have in place, they could search the EMPI to actually pre-populate the patient demographics. We'll know who you are, so we'll pre-populate the provider information and send that information off. So there's a variety of things we can do.
And then, Oliver, I think this follows along with what you just said about the PDF, but if someone wants to print out the form for patients to have a copy, they would just be able to do that with a PDF that's produced from filling out the form, yes?
Yeah, and the conversation point we're actually having with health information management and the clinics themselves is what does that PDF look like? And give me 1 second, because the conversation point. I'm still sharing my screen, am I?
Yes.
Right. Okay. So, because this introduces an interesting conversation, which we need to resolve. It's not going to be difficult. We just need to do it. There's your original requisition. This is what it looks like. And fits perfectly onto an 8.5/11, all nice and lines. Now we've optimized the workflow. We've actually made it more user friendly. Fantastic. So what's over here? What does the PDF look like? Do we go back to this? So it actually looks like this, and try and squeeze all this back in here. So for example, if we've given them a lot of room to actually type a lot of information, if we try and squeeze that back into the box, that doesn't sound like a lot of fun. So what does that look like? And I'm not suggesting that this is the outcome, but is there a way that we can actually generate just some information and generate that PDF so that it actually, the information is actually there in a usable format, which doesn't confine us back to the original requisition. Those conversations are still outstanding.
Oliver, we have a couple more questions and a lot of feedback to take back, and I think maybe some separate discussions to have just to dig deeper into the technical side. I know we only have a couple minutes left. Maybe let's try and power through the last few questions. I don't want to dig too much into the time for the second session. So one of those is about, we deferred it a bit earlier, but the change of EMR ownership and acquisition and whether that's going to impact the rollout time and the current plan.
From the acquisition perspective, so there are two EMRs which actually haven't signed on to do this by the fall. One is Plexia, used by specialists, which has been acquired by Medfar in Quebec. The BC operations really want to do this. They've been at the table for us for a while. They're just prioritizing other work with their new Quebec masters. So they will come along, I'd expect, within the next 6 months. And the biggest holdout is actually TELUS. And TELUS did their recent acquisition, as someone mentioned, of Input Health.
Surprised.
The individual who ran Input Health, Damon Ramsey, he actually wanted to be part of the proof of technical integration back when we did it, because he saw this as the future. This was fantastic. Let's get involved. We didn't have the capacity to support 3 vendors, so we only supported the 2. So that gentleman now actually runs the EMR operations at TELUS. So I think we're very well positioned from a TELUS perspective to actually have Damon, when he gets around to it, after he's got over the initial hurdle with his new job, to say, yes, great, fantastic, this thing, I loved it before, I love it now, let's actually start to move down that path. So slight delay, but ultimately, no.
Yeah, and for Oscar, no, we're not expecting a delay. Like we have a couple of options, I'm going to say, for development, but in terms of if you're a Well Health client and you're specifically wondering about Well Health, like we have been in touch with them, and their acquisition of IntraHealth does not seem to be impacting the timeline at all.
Yes.
We're not currently concerned about that. So they're still, I'm going to say, on board potentially. We're in the very early stages, as Oliver mentioned. We're still doing like the technical evaluation. We're working with all the partners. We're working with Officer BC. But this isn't something like we have talked to them. And we don't expect this to be I'm going to say, a problem. We don't have timelines from the vendors, because now I think we're getting questions about the other OSPs. So I think for us, the question was really, do things slow down after someone has made an acquisition or been acquired? So that's a bit of a separate conversation that we've had specifically with Well Health. We do not have exact timelines for the OSPs, because the technical analysis for just generally the Oscar code base is still in progress. So at this point, we can't get timelines from the OSPs other than we think this will probably be able to be done by the end of this year, until we really understand what that integration looks like. So it's just too early in the process for us to start calling out, like, they're going to be in November, this OSP is going in September, or that sort of thing. But we can be in touch with updates on that as they come, probably after we finish that initial analysis and start having those conversations with people. So another question, Oliver, do you want to just recap your reply about attaching PDFs? Because I had a few more come in. I know you answered that, but just sort of what's going on with that and when is it coming, or if we know when it's coming.
So what we need to do to overcome that is, one, have a fulsome review of how Smart on Fire supports attachments, which it does. We just need to familiarize ourselves with what that looks like. Have a conversation at the architectural level around, is there anything that we globally need to do to support all the vendors, and then have those individual companies with the vendors as part of their implementation. So I think from a commitment perspective, we will get there. It will be supported, and it's just a matter of actually figuring out what that looks like.
Okay, so
worst comes to worst, if we are delayed in doing that, not suggesting any word, there's a lot of forms out there that don't have attachments. So again, when you look at which forms you want to start with the ones that don't have attachments.
Okay. We're gonna take the last two because they're very quick, and then I just want to confirm really quickly with Ken and Cindy, are we able to save this chat log and have a copy? Because we have a lot of really good suggestions coming in on top of the questions. And I want to make sure that we have those documented. So otherwise I can screenshot them. I'm just double checking.
Yes, I believe we can, Rachel.
Perfect. Okay. Love a copy of that after, just to make sure that we have these documented. So if you're able to do that, I won't worry too much about it. So the last two questions, Oliver, was around the shared drafts functionality. So what happens if I save a form completed by another provider? Actually, can I see forms completed by another provider after the fact in the patient records? So I think it's a bit of a question around, like, when you get that PDF back that you've completed the form, what happens to that, and can people see it?
Yeah, so our relationship with the vendor is you guys figure that out. So the vendor figures that out, because what we do is we hand it back. Where that gets stored, the permissions put on top of that, that's entirely up to the EMR. So that's really an EMR-centric conversation.
And then the very last question that we're going to take is, how real time is this? So if I'm a form owner and I go in and I update my form at 9 in the morning and someone pulls this form at 9:02, is it the real time updated copy of the form? How quickly does that turn around?
So right now within our production environment, as soon as we actually make a change to our production environment, it actually gets immediately available to our downstream users. So literally, the process would be a form owner would say approve it, we like it, fantastic. We go through our change management process, and 9 o'clock that night, we'd sit there and great, we're going to promote all these things into production. 9:02, actually no, let's go with a scenario. 8:57, someone actually opens up a form, looks at it, completes it. Right? If they go back 9:05, it'll actually be the new form. We do recognize that 8:55, someone might go in there and complete a form and save it. So now we've got the old form in there. And then 9:05, there's a new form, and we just recognize that there'll be a period of time where both versions will actually be accepted.
Yeah, and I think really just what that means is we do have a change management process behind that. So there is a period of time between when they want to change their form and when it becomes available. And it is about us promoting it into production. So it's just something where we would work with form owners to make sure they're communicating appropriately, to make sure we're notifying vendors. So the vendor says, yes, I want to have this form in the EMR. And once the form is there, the updates come out automatically, and we're managing things like timelines and making sure the beta is done and approving the form and then getting it published in the back end. So it just sort of pops up for you.
Yeah, and actually, sorry, one other consideration. Yeah, for any changes, I think we would go through a decision-making process to say, what's the likelihood that this information would actually already be in the EMR, i.e., is there an opportunity for auto-population? Lower mainland medical imaging. They want to add a question, are you willing to travel? Okay, so is there a chance that that's documented in OSCAR? Probably not, highly likely not, let's say no, okay? So because of that, we might decide not to actually give notice to the vendors that, by the way, we're changing this form in a week. We might actually just expedite that and actually make it live right away. If there's another change where, okay, well, now we're going to add height and weight, well, there is an opportunity to actually pre-populate that. So this is something which the vendors might appreciate being given a heads up on, because they might want to actually try and actually add those hooks in there to actually allow for that pre-population. So we got a decision-making process there to go through.
I think we need to hand it over.
Back to Ken.
Okay, thank you very much, Rachel and Oliver. And that was interesting. Every time I listened to you folks, I learned something new, which is great. And I hope everybody participating also gains some benefit out of that. And I know there'll be more and further follow-ups, and certainly, if you've got further questions, if you don't want to get bombarded, I don't think, but please do submit them through OSCAR BC. We'd be happy to follow up for you.